In which case, good afternoon, everyone, and welcome to the Council of Governors meeting this afternoon. A number of apologies, which Nicola will let us have now.
Yep, I've got apologies from Fiona Wilson, Frank Bennison, Lawrence O'Connor-Reid, Michelle Brown, Cal Spencer, Lee Outhwaite, John Court and Keith Nurcombe.
That's super. Thank you very much. Keith has two children at home unwell with COVID today, which is why he can't be with us. But we have a number of apologies there from executive colleagues, which you will have noted. And I have said to executive colleagues that they're always very welcome at COG and we will be very pleased to see them. But if the operational pressures are such that they feel they need to prioritise being elsewhere, that they should, feel free and able to do that. So it's in that context that we have those apologies from executive colleagues today. The next item are verbal questions from the public. We haven't had any in writing, and to the best of my knowledge, we don't have any members of the public on the call at the moment. But if members do join us, they're always welcome to enter questions and we will deal with them at the end of the meeting. Or indeed, if members of the public look at this recording, not in real time, but after the meeting, and they have any questions, they're always very welcome to contact us at the hospital and we'll deal with them between meetings. There's no need for there to be a meeting in order for you to be able to be in contact and raise any issues or queries that you may have. So that offer is there. And then that brings us to the next item on the agenda, which are under the heading of services being well led. And the first item is the Chief Executive's briefing. So Angie, if we might go to you for that, please.
Thanks, Helen. And as always, the report is out of date the moment it's written in recent times. So just a quick update for everyone. As of today, 38 COVID inpatients in our hospital, with none of them in critical care, which is obviously always the real positive. So numbers coming down. Still a concern around Omicron in the community, particularly amongst school-aged children at the moment. So by no means out of the woods. And as Helen said, our colleague with poorly children at home in the minute clearly has an impact on our staffing abilities. Pleasing to note that our sickness absence has come down. So we hit a high of 11% a couple of weeks ago. We're back down to around the 7% at the minute. So still a little higher than our average of around 4 to 5, but going again in the right direction. And also pleasing this week that our elective programme is back up and running as well as it can be. So that's really good news for those patients who've been waiting for their elective procedures. And the other area, just to give an update around the compulsory vaccination as a condition of deployment. Obviously that became out of date on Friday, but a huge thank you to all our staff and all our teams who have worked really hard up to the 11th hour of trying to ensure that as many of our staff as possible have had their COVID vaccinations. As of today, and it does still change, particularly staff who are on maternity leave, for example, or staff updating when they decided to have their vaccinations. But as of today, 96% of our staff have had their first vaccination, 94% their second, and 79% their booster. So a really good uptake. It varies across the region and across the country in terms of impact on organisation, but pleasing to note our good uptake, and still work to do. It's obviously still subject to parliamentary ratification, and there's work to do with our staff, supported through their managers and HR, around what that means for those who still haven't been vaccinated, although it's not a condition of deployment any longer. And I think there, I'll pause, Helen. The only other mention since we last met as a council is obviously the planning guidance was sent to us as a nice Christmas present on Christmas Eve. Lots of work ongoing around that, some of which you'll hear as colleagues update later on the agenda. But also to note that the delay to the integrated care system implementation, still July as we sit here today, but again, we'll wait and see how that progresses. So happy to take any questions.
Thank you very much, Angie. Margaret.
Hi, Angie. Just a small question on the vaccination. I mean, well done for getting 96% of staff. But of the 4% of staff that haven't had any vaccines, have you got a sense of, or do you know the figures of how many of those are sort of patient-facing operational staff, or and how, you know, so if we were, you know, just sort of a feel, because I still have a worry that although the government has now U-turned on this, if we get another variant, things could all be back in the mix again. So just to give us a flavour of what would happen if that was the case.
And it is spread across all areas and across all staff groups. So there are a number of areas that divisions are concerned about, whether that's from a ward area. There's a few hotspots that they're worried about. So we know that there are people in what we term direct clinical care. As always with national NHS directives, it's a bit of a grey area. So and there hasn't been an absolute clarity of what patient-facing means. So there's a bit of interpretation. If you work in estates and facilities and you're often on the ward fixing things, then most of us would count that as a patient-facing role. So that's where that work I referred to with the HR managers and line managers is still ongoing, because to work through all of that on an individual basis is what we're focusing on. So we give the individuals the support, but also make sure we keep our patients and colleagues safe too.
Thanks.
Norman.
Hi, Angie. Are you saying that the staff who haven't been injected at all will be redeployed from areas where they're face-to-face with patients? If so, you're not saying that?
No, that was the original plan, that staff would be redeployed to non-patient facing areas, or worst case scenario dismissed. But that's the U-turn, that now that is not the case, which is Margaret's question around what does that mean for individuals where we have still got them unvaccinated, and the risk assessments that that we do with individuals depending on where they work. But it's not a mandated message as it was up until Friday.
Okay, so that applies to governors as well then, doesn't it? Because you know, if we're going on towards, then we're in that danger area, if you might call it that. However, I raised earlier with Helen, what is the level? What is the risk level now? Is there no risk?
Yes.
Are we saying it's okay not to be injected and you can go on to the wards?
There's still a risk while ever Omicron is present in the community, and while ever there are new variants appearing, there is always a risk. And vaccination, while it reduces the risk, doesn't completely eliminate it. So all the measures, and Krishna and Sarah may want to come in, all the measures that we ask everyone to follow all the time are still very much, whether that's mask wearing, hand washing, distancing where we need to, we're still following that. None of that has changed. Whether Krishna wants to add anything to that?
No, I mean, you're better to be vaccinated than non-vaccinated, in my opinion, because it does offer that protection to yourself, patients, families, but it is a personal choice. We've had some, especially Sarah's been our guru on a number of fronts, because obviously, you know, we've got a predominantly female workforce who were concerned with all sorts of issues such as fertility issues in pregnancy, and we've had a number of one-to-one conversations with our teams, really, to try and dispel some myths, give them sort of the information for them to make an informed decision about what they wanted to do, whether they wanted to go ahead with the vaccination or not. It's absolutely personal choice. It's just unfortunate that we've had this U-turn sort of quite late in the day, really, because we've been quite a way down with having those conversations with our teams.
Krishna, I just wonder, whilst you're on a roll, if you might be kind enough to comment about how soon it is we think we might be safe and appropriate to get visitors back on site, and consequently arrangements for governors.
So we're making a decision on Friday about whether we start to introduce designated sort of visiting from next week. We've done a straw poll sort of with surrounding hospitals, and there's a mixed reaction about what they're doing. But to us, it's a risk not having visitors for a lot of our patients. And, you know, people will still be on site wearing masks, good hand hygiene, and being safe distance. But actually, we'll take that informed decision on Friday. We just keep monitoring some of those transmission rates. As soon as that's the case, then absolutely welcome sort of visitors, so governors and NEDs on site, and a number of NEDs have already had a few visits sort of with us. Again, it's using those sort of same precautions, but you know, we're going to have to live with numerous variants as we go forward. We just need to do it sort of in a safe and sort of managed way. So again, visitors, it's not a free for all. It will be every patient to have a designated visitor on that day, the opportunity to have that. And we'll do that, and we'll monitor and see about any outbreaks and if there are any adverse consequences as a result of that. And we'll just keep a really close eye on it, which is what we did before.
Helen, can I just add that recently, lately at Walton Hospital, I'm still volunteering up there for the vaccination, and we've had a hell of a lot of health staff turning up saying, I don't want to be here, but I've got to be here. Before this news came out on Friday. So the fact that the threat of losing a job or whatever was getting the vaccine into people's arms.
It was.
I now think that because of that, I mean, a couple on Friday said to me, we've come for the vaccine, but we don't want it. We've got to have it because we've been told we've got to have it. So at least it was getting it into their arm, but I think, you know, that letter would have turned them round. They wouldn't have had the injection. So it's having an adverse effect, I'm afraid. Thank you.
Norman, two further things to add. You talked about the vaccination status of governors briefly, and just we spoke about this, didn't we, the other day, but just for the record, it's our intention to ask governors for a voluntary declaration of your vaccination status. There's some NHS providers are giving this some consideration, they're taking legal advice, all the rest of it. I suggest until they've resolved all of that we just leave them to it. And in the meantime, that we ask governors for a voluntary declaration. So if you're happy to tell us. And if you're not happy to tell us, we can, deal with that subsequently, possibly in the context of a risk assessment about attendance on site. But yeah, that's where we're up to on that. Now, Judith previously raised some vaccination-related questions, specifically around hospital-acquired infections and what's the current state of play with hospital-acquired infections. So I might just pose that to you now, Krishna, rather than later, as we're kind of on a vaccination theme.
So we have had, so COVID, as we know, sort of during this wave, is that we've had the patients that we've got are coming in with other ailments and happen to be COVID positive. So we always do a swab on admission, which has been negative. And then when we do day 3, day 5 swabs, if they become positive, that we would class that as the patient having acquired it in the community. And with high prevalence, we've been seeing more and more of those patients coming in negative, but then moving to positive. What that means is if they're already in a bay, so if they've not got any symptoms, which many patients haven't of COVID, if they're already in a bay, then we would class the other patients in that bay as COVID contacts, and we would separate, if you like, we'd move the patient who was positive into a side room or onto a ward with other positive patients, and we would keep that bay closed to any further admissions and doors closed and other precautions in place, and monitor, and we would swab. So where we get 2 or more patients or 2 or more visitors or any combination of positive, then we would class that as an outbreak, and we would declare that to NHSEI from an outbreak point of view. We have had a number of outbreaks, as we would have expected, with that being the case, over sort of the Christmas and into January. They are subsiding now, but we still have a number of beds closed because we wouldn't admit into that bay if there are other patients who are positive. So it is causing us quite a lot of operational pressures in moving patients around or not moving patients around and closing different wards off. And that's the fine balance between having more footfall in the organisation and having visitors in and not. It is quite a careful balance, which is why we'll reevaluate it on Friday. So we have had a number of outbreaks. We're not out of kilter with anywhere else, and HSEI are invited on our outbreak meetings, as they always have, with our CCG colleagues to see if there's anything that we can learn, anything that we've not considered. Invariably, we get good feedback on that we've gone into that ward. We were swabbing staff at one point, and now we're not. As changes have been made, it's more going on lateral flow tests for our staff, which we've been doing right the way through the pandemic anyway, on a routine basis. So things have changed, but as far as hospital-acquired infections, they have started to reduce now, along with sort of most of the trust, to be fair.
Thanks, Krishna. Bernice makes a kind offer in the chat to just talk about the impact on nursing and care homes about outbreaks. You might also want to just talk a bit about vaccination issues there too, Bernice, if you would.
Thanks, Helen. That was more for Krishna. She's certainly been involved in this, so it was just to obviously highlight to the governors that at points we've had up to 60% of our nursing and care homes in outbreak as well, which has really impacted on our flow. And that doesn't just impact on the flow out for discharge and people to the right place. It also helps. It also impacts on the manoeuvrability of what you can actually do within the bed spaces that you've actually got within the acute hospital. So it was just with Krishna talking about outbreaks and the restriction of visitors, you know, the impact of vaccination and good hand hygiene and everything. We've had to really up our game with regards to that, because we've had limited capacity, given that we've had up to 120 patients that we haven't been able to move out of the organisation. So we've almost been working with a third less of our bed base at times. So it's just worth mentioning that with regards to the vaccination in the care homes, obviously the instructions came in slightly earlier for care homes, so they had already enacted it, and we don't know the numbers, but there were some people that absolutely did lose their jobs as a result of it. But thankfully the domiciliary care market is in with the same timelines as the NHS, so that's under the same review as everybody else at the moment. So thanks, Helen.
Thanks, Bernice. Reduced flow and the extra pressure on staff, as Luke mentions, absolutely. As I always say, Angie, the measure of good chief exec's report is how many questions and comments it provokes. So that was another cracking one. Thank you very much. And we'll leave that there and move on to the next item, which are the success measures and the items that governors particularly want visibility and the ability to hold NEDs to account in terms of delivery. So with a number of apologies today, Jane Stringfellow is going to be worth her weight in gold as the understudy for those who can't be here. But in any event, Jane, you lead off on the first of the success measures about integration and amalgamation of services. So if you will be kind enough to lead the charge.
Okay, so the first success measure related to the achievement of the bronze accreditation for the wards by March 2022. And we had a bit of a discussion at Council of Governors previously, and then subsequently Margaret and Krishna have met to discuss this, because clearly because of operational pressures the care accreditation scheme has not been running, but still we wanted to know and understand how the quality of care is still being measured across our trust, because clearly that is really still very, very important. So whilst we might not be doing the formal system, there are other things that we have in place. So I think a little bit later on the agenda, you're actually going to get a full presentation on this, Helen. So that is in lieu of the narrative from me, but just to be reassured that we still have our finger on the pulse, we still are looking at quality, we still are running quality assurance committees.
Thank you very much. Jeremy, can we go to you next, please, for the whole of the kind of people agenda?
Yes, thank you. Well, colleagues will have had a chance to read the update in the papers. Specifically with regard to outcomes, we draw on two sources of information. One is the annual staff survey, and although that was completed, as you all know, in the autumn, the results are not yet published, although what we do know is that we had a really pretty good response rate in the circumstances, certainly higher than last year and higher than the average for the other trusts that are surveyed by Quality Health. Obviously, as soon as the results are publishable, we will share those in full with Council of Governors. And the other source is the information in our People Strategy Success Measures, which are essentially drawn from the performance report. Overall, well, the summary of those is in the report there. I'm clearly very happy to take any questions from any governors on that.
Thank you very much, Jeremy. Does anybody want to raise anything on the back of that update from Jeremy, or indeed the written report? No? Now, I don't think, Jane, you were anticipating adding much to the report that Keith's provided in writing, both on the system working item at number 3 and also on the primary care interface at number 4. But if colleagues do have any questions, Jane and all the NEDs, and indeed Angie and Berenice, who respectively lead on these items 3 and 4, will be happy to take any questions that colleagues may have. So is there anything you wanted to raise in that whole space about system working first off? I wonder, Angie, might it just be sent? Oh, Berenice, sorry.
Thanks, Helen. It was only in addition to the outcome for number 4 and improving the working across primary care.
Just hold that thought for 2 minutes. I'm going to come to you in 2 minutes and we'll do number 4. Just before we do that, let's do number 3. Angie, do you think you and I should do something of a duet just by way of an update on where the system's at, because it's so fast moving? Are you happy to just talk about timings and all of that good stuff?
Yeah, okay. So in terms of the governance structure around integrated care systems, as I said earlier, that will be from July as we sit here at the moment. And there's recruitment to the non-exec director posts and exec director posts for the ICS in progress. The development of the integrated care partnership, which is the joint work with local authorities, is just being pulled together. So as people will remember, there was a Joined Up Care Derbyshire board that had a lot of health representatives, but did also include local authority and voluntary sector. In the new legislation, that expands that focus on partnership even more. So the partnership will be local authority chaired, with health representatives around that table and focusing on the strategic areas we want to work on in Derbyshire to improve the health for Derby and Derbyshire residents. And then the Integrated Care Board is an NHSism, as I call it. So that's purely NHS that reports into, if you like, the more traditional assurance performance management type work, but doing it differently. So commissioning and provision round one table, again, focusing on what's the right thing to do for our residents to address health inequalities, etc., and still with local authority representation at that table too. And reporting into that are a number of work programmes, delivery programmes, that are the doing bits, if you like. So some of the success measures that you see here, if we pick Team Up, that was the one that was used, Keith and I put in the paper, then how that will make a difference to our frail elderly population is part of the programmes that are delivering into that NHS Integrated Care Board. So it isn't, although it's health focused, we can't do any of that work without our care home colleagues, without primary care and secondary care working closely together. So that is a very simplistic and I hope helpful position of where we're at, Helen. And again, happy to take any detailed questions on. There's a huge amount of work happening, and Berenice, if she's going to come in, may want to just touch on Anchor because she leads that work for us.
Very good. Well, delightfully simplistic, I'd say. It's a real art to make simplicity out of complexity, and there's plenty of that around at the moment. So it's really helpful to have the very latest in system working and those headlines. Thank you. Berenice, please add a bit about Anchor, and when you've paused for breath, take us on to the whole issue about Success Measure 4 and working closely with primary care.
Thanks, Helen. The Anchor information is as per included in the paper. There has been a bit of a pause on some of the meetings to kind of gather information. We have done a recent survey and we really focused in on how far we've got with some of our procurement, looking for kind of local businesses, local workforce, local materials to provide some of the services that we require, and that is all on track for putting into kind of contracts from April 2022, which is really positive. And there has been some small successes, I think much larger successes at Chesterfield, because we've been working as an Anchor organisation for quite a long period of time. Some real success around recruiting people and building and developing those people to want to come and to work in the workforce into different roles within our services. So some real positivity in Chesterfield itself, but we haven't gathered all the information from the other organisations as yet. There's a meeting mid-February, so I'm hoping by the next Council of Governors we'll be able to give a much more thorough update on Anchor.
That's super. So we just poise on Anchor for a second. Anybody else want to come in on Anchor? Any other bit of system working? No, in which case let's note that report. And Berenice, if you'd be kind enough just to give us the latest on item 4 and interface with primary care.
Thanks. So I just wanted to add to the narrative that had been submitted, just to say that there is a provider board now being arranged with all the PCNs, which is going to be led by Steve Lloyd. And that is going to really help us now focus on some of these integrated pathways. We've been currently working with PCNs individually and really struggled to get some of the information around the developments that we're doing collectively within the acute sector or in the community or in social care, and also what is primary care doing, and I think this will really help us with that interface. So all the clinical leads from the PCNs will attend that meeting, and we'll find that a really helpful way to start communicating with each of the services. We have developed some pathways. The cardiology pathway is a really good example of that. But again, some of the hurdles from a financial point of view is preventing us getting it over the line, and we need to make sure that that doesn't stop us. You know, we have to test some of these pathways out and let the finance side of things catch us up. So we are making some progress on it.
Not without great tenacity and determination from you around all of this, Berenice, for which we are duly grateful. The other items on there about the other pathways like urgent care, elective care, outpatients, diagnostics and cancer, I think we're going to come on to in the next agenda item, which is about restoration and recovery. So we probably don't need to say too much more about that now, which then brings us to Success Measure 5, which is all about digital services and also about innovation and the Improvement Academy. We haven't got Sue with us today. Poor old Sue's got a massive migraine apparently. So I think she's taken to her bed. But the main development in that regard has been with regard to the digital strategy having been presented to the last board meeting. And I really commend it to you. I mean, I wouldn't lightly commend a digital strategy to anybody, but this is extremely digestible and a great testament to having a clinician who really knows what the purpose of the technology and the deployment of the innovation means for people who work on the front line in the hospital. So it is, digital innovation in support of patient care and described as such. And I mean, I've had nothing to do with it, but I feel very proud of it. And I think it's a great, benchmark in terms of describing that whole approach to innovation, clearly. The other thing that's really been keeping John busy is that what was NHSX, the kind of digital body, is now kind of being slowly wound down and wound into the kind of a kind of consolidated focus nationally on digital. And he's very much looking forward to that, in that it will simplify and streamline and align. But practically, and I know this, John's office is next to mine, he's managing that transition in terms of the requirements of various colleagues nationally. And of course, that's particularly acute at the moment, if you'll forgive the pun, with respect to the funding bids and submissions. And I know John has been very active in that regard, in making sure that we are applying for funds where they're available, but thoughtfully, in a way where we know that they will really have best effect. So I think there will be a further update shortly for board and for governors about the implementation of the strategy, not least of all, hopefully on the back of our success on some of these major capital bids. So I don't think I'd say much more about that for now, but if anybody's any questions, very happy to have them. Margaret?
Well, thanks. Just a couple of observations and then one small question, but the observations are, certainly from my perspective, this report, I found this really detailed and usable, and if we carry on like this, there won't be that many questions because everything's said in the report. So I found it really helpful to see where we are in all the things that we're particularly monitoring. So, but I am conscious reading through them, especially some of the system stuff. It could be quite difficult for our new governor colleagues because the language is quite tricky to get your heads around. So if I can just try and reassure our new governor colleagues that we will try and have some sessions to get people used to this kind of terminology and what's happening in the system as best as we can. I mean, it is changing so very quickly, but at least if you can try and understand the structure and the way of it. So, as part of your induction, we will endeavour to try and do that. In the meantime, if anyone's got any specific questions just about that sort of thing, I'm happy to try and help out as best I can, or Nick, I'm sure we'll field any other questions through to people who are relevant. And the question really, just thinking back to our special Council of Governors to approve the external auditor, we did talk about some sort of monitoring of the auditing, and we talked. We've shared a couple of emails since then about how we're going to do that. I wondered if it was an appropriate time to actually talk about that now.
That's a really helpful reminder. So colleagues, remember that we had the extraordinary meeting of the Council of Governors to approve the new internal auditors last week, I think, from recollection. And that was subject to an enhanced monitoring regime. And I, bless me, suggested that might be encapsulated or incorporated within this report. It was no sooner out of my mouth than I thought to myself, I've given my colleagues a whole load of hassle and trouble with that suggestion. So Margaret and I exchanged emails subsequently to say it should probably be a standalone report that maybe comes 6 monthly. And I think that will give colleagues more freedom to report in a really relevant way to external audit issues, rather than us try to shoehorn it into a kind of success criterion and not do justice to anything in the process. So if everyone's content, that's what we'll do.
Thank you
for that. John, please.
It's just a plea to everybody, because I'm new. If you're going to use acronyms, Could you follow it up with a little description about what the acronyms are? Thank you. And thanks for the offer of help. It's always appreciated. With the IT systems, from a patient perspective, working through GP practices, we now have an integrated ability to look at records, book appointments and things through GP practices. Is that going to be integrated together with the hospital systems so that the GPs and the hospital systems can actually talk to each other? That was my only question. Thank you.
The answer is yes and no. So, I mean, there's colleagues who probably can do more justice to this than me, but there is a convergence strategy, yes. But the convergence strategy is a pragmatic one about convergence for people who are on the same systems, yeah. So, for instance, we have visibility of systems, for example, with South Yorkshire for people on tertiary referrals, yeah. Or we have visibility of systems with most of primary care, yes, that the primary care that's in the surrounding areas of the hospital. We don't, for example, have visibility of systems where we have vascular referrals to Derby, yeah. So where the systems are compatible, yeah, there is a strategy of data alignment. But the systems aren't compatible, there's a strategy of having compatible hardware over a period of time and subsequent data integration. So the objective is there, but it is taking a little time to march towards it in bite-sized chunks. And is there anybody better qualified to describe that in more technical terms than me?
Simple answer, no. Thank you. Very good summary, I think.
That was my attempt at simplification. And you are having a presentation from John at the next Council of Governors, so you'll get the full fat version of the answer on that occasion. Norman.
A question for Berenice, please. What's the progress with the patient hub? Are you still progressing with that, and how would a patient access that hub?
Thanks, Norman. The patient hub is underway. It's operating. The bit that we haven't got off the ground is the focus groups to help the further development. So I have given Claire your name as an interested party. I can see I've frozen again, so I'm going to get kicked out of Teams. Apologies, everybody. But yeah, we still need to progress the actual focus groups. But it is an app. I shared a presentation the last time that patients download, and then they can follow their whole progress. They can see where the waiting times are, when the next appointment is, what the latest update is. So if anybody wants any further information on that, do just shout. But I will progress the focus groups for you, Norman.
Thank you.
And as a user of the new technology in the last few weeks, I have to say it's really impressive. And I'm so impressed. We're going to be having a presentation at board. I think anybody who mightn't normally get to see it really deserves to see it in action. It's a great step in the right direction. Berenice, there was a question earlier from Mike Grundman that now might be the right time to raise it rather than later. And he was talking about one of his constituents who had a requirement on discharge for daily dressings. And the GP didn't have the capacity to do daily dressings, and Mike was referring back to the halcyon days when he was a consultant to the hospital, and it all happened seamlessly through a referral from the hospital to the district nursing service, and that doesn't seem to work the same way now. And he was just working, he was not asking questions about why didn't it work on this occasion. He wanted more clarification about how is it supposed to work now. You're on mute, Berenice.
I don't know whether it's kicked her out because.
Or maybe.
And Sarah's going to answer for us.
So how it should work for a daily dressing is, as you say, a referral through to the district nurse for them to pick up that requirement. Why that hasn't worked, we couldn't comment on an individual case unless we had the permission of that patient to go through that, but we could do that for this individual. but that's how it should work. And we are progressing, ever increasing joint working with the community tissue viability team as well, so that we have a seamless process for complex dressings, because there are some that are outside of the skills of a straightforward district nurse attendants that would require that tissue viability expertise. So we're progressing joint working and a joint, so when you mentioned system 1, that's a really good example of how we have that system now for our tissue viability team to be able to maintain the care plan. So when the patient is discharged, that's the same plan of care on discharge.
Yeah, sorry, when referrals being made to the district nurse, is that just for domiciliary care, or can patients attend the district nurse in wherever their headquarters might be?
It will depend on the locality of the patient and the locality of the district nursing team. So and the patient's condition. So that may be, if that's a housebound patient, that would be a domiciliary visit. If not, it may be a practice nurse visit, for example, into the practice where the patient is able to do that. So it is based on an individual assessment and a liaison with the district nursing team when that referral is being made.
But that obviously didn't happen in this case. Anyway, we'll leave it at that.
And it would be good to, and we can pick that up separately to understand how that's failed, because we need to fix that failure.
Okay, thanks.
Welcome back, Berenice. Sarah did a very good imitation of you in your absence. There was another question raised earlier that, again, I think now might be a good time to take it in the context of this report, which was about the fabulous new urgent care treatment facility we're going to have, but a particular question about the approach to paediatric assessment. And governors were recently sent an update including all sorts of details of colour schemes and all sorts of weird and wonderful things about our new building. But it has triggered some questions about how that paediatric assessment pathway is going to work in the context of the new build. Are any of our colleagues able to comment on that? Krishna or Berenice or Sarah?
Helen, I don't know if you can hear me okay. Can you?
Yes.
Yeah, so what we've done very recently, I think it was the 7th of January now, because it's there's been a lot happened in January. We shut down 6 beds in the paediatric area to allow us to do the development that we need to as part of the urgent and emergency care department development. What we've established is a paediatric assessment area, which is kind of 3 hours and 59 minutes. That's as long as you're allowed to stay there. If you stay over 24 hours, then you're an inpatient. So it allows people to move directly from the emergency department into that paediatric assessment unit, be assessed by the consultants and the advanced nurse practitioners between them, because we've got some great roles in there, do some observations and hopefully turn people around again at the front door, a bit like any of the other assessment units that we have in place. The one concern was that we didn't have the right infrastructure in place to be able to support the actual pathways, and therefore it would result in patients spending, certainly children spending too long in our current emergency department. And as you well know, the infrastructure for our children in the current setup at Chesterfield is very, very limited. So that was a real concern. So the consultants, nurse practitioners, the management team have worked through a pathway. We've got a developed SOP, and that was implemented. It was signed off by everybody and implemented, as I say, about the 7th of January that they put that in place. The Catherine Lendrum, the clinical lead from the emergency department, played a big part in this, and has certainly been supporting with the pathways and escalating if there's any issues. We have just this week asked for a report because we're obviously monitoring how long people are staying in the emergency department and how effective the actual pathways are. So we can certainly report back at a future meeting around the success. But I think on a positive note, everybody from a clinical point of view is reporting that the pathways are working well, and we've certainly had no issues escalated to us. So sorry I missed the start of your conversation. If there's anything that you need to escalate back to me, I'm happy to take that back.
Thanks very much, Berenice. Very helpful. Norman.
Sorry, Helen, I think that was an old hand.
Old hand, no worries, no worries. Well, the last item I'm going to weave into this report came from our earlier discussion, and it was in respect of a relative of one of our governors who'd had a recent inpatient stay. And we can obviously reflect on the details of that at another time. But the more generic point relevant for today, and probably under actually success measure 1 with the whole quality agenda, was, if I was to paraphrase it, it was a kind of strange, an experience of a strange balance between laxatives vis-a-vis fruit and vegetables, and the former seeming to be in plentiful supply and the latter in more scarce supply. So you know, it's obviously an important and serious point, and indeed one that government been close to over the years in terms of, as we used to beautifully describe it, the patient feeding contract. But the whole issue about nutrition and what have you is an important one. I don't know, Jane, if you'd like to take that away, or if there's anything you can offer by way of observations from the Quality Committee, or...
I can't offer anything further, Helen. We can ask the questions through Quality Assurance Committee, unless there's anything specific that Krishna would like to add this afternoon, but we can pick it up in February meeting anyway.
Okay. Anything you'd like to add now, Krishna?
No, I'd be quite happy to sort of have a conversation sort of offline just to understand some of the specifics about it a little bit more, because it's not something that's been raised before, different aspects of food, but not that. So I'd be really interested to hear offline. Yeah.
Yeah, very good. Well, we will make sure that happens. So thank you for that offer. Now, we have one more hand, and it's escaped on me, so I better go and find it. Oh, Mike, is that a new hand or an old hand?
I'm afraid it's a new hand.
A new hand, that's
yeah,
loud.
Just to say, this is not a new problem. I seem to remember about 30 or was it 40 years ago when I first started raising the issue about high fibre diets on patients' food. And it improves for a time, and then it sort of seems to slip back, and the amount of fibre decreases. Anyway, good luck trying to solve it.
Says the voice of experience. Well, that's a good challenge for you, Krishna, and a helpful bit of context that, you know, you might need to be the person to finally solve it for once and for all. So I think we're going to leave that report there. I just want to check, though, because I'm very conscious that we've put the integrated performance report kind of as a noting item for governors, and that has had mixed press, including from Dr. Grundman. So if there was anything on the performance report that you'd picked up in the context of board or otherwise that you wanted to raise anything on, now is a really good time, because of course governors don't have to restrict themselves only to the report in front of them. Pervez. You're on mute, Pervez. You need to come off mute and shout.
I have 3 small issues with regard to integrated performance report. The first one is the mortality, and typically if you want to show someone mortality ratio, you will have a graph which will have odd ratio and which will have confidence interval. The way information is displayed in our quality report, fortunately, has neither the odd ratio in numerical terms and not the confidence interval. So it's very difficult to work out if we are below other trust, comparable trust or not. So that's the first thing. The second thing is length of second thing is number of patients who got readmitted within 28 days of discharge. We have already heard that our bed base is very tight and these patients are waste economy in many respects. Now, the comments which came with the report that this is an expected level, that's 14%. And I would beg to dispute, 14% is very high. That's every 7th patient. And we must have an ambition to get it low. And the third point about the integrated report is about the non-event things which should never happen. And so far we have 6, but we don't know what are these 6. We need to know that these never events are properly monitored and labeled in the appropriate part of the hospital.
They're great questions. Thank you very much, Pervez. Jane, can I come to you in the first instance, please?
You can. So I'll go 1, 2, 3. So on mortality, when we redesigned the IPR and we were looking at using the different methodologies, when we got to mortality, we had some conversations about how that should be or should not be displayed. So I will ask the team to look at that again and speak to you directly, Pervez. We have got some issues at the moment in that some of the data is not being collected nationally. I think is it called Telstar now rather than Dr. Foster reporting has not been happening, and that has affected the reporting on mortality more generally. So that's not about how it's presented, that's just about how up to date it is, Pervez, at the moment. But I take your point and we can revisit that. Always grateful for a challenge on how we're displaying our data. The second one on readmitted, again.
Sorry, Jane, just before you go on, I absolutely we'll take the presentation issue away, but there's no issues that I'm aware of in front of quality at the moment where we have any concerns about any outlying situation on mortality.
So we've been particularly looking, as you know, over the last year or so at stroke, at congestive cardiac failure, and more recently at hip outcomes, hip fractures. And all of those things are reported every single time to the Quality Assurance Committee, Pervez. So mortality reporting is one of the things that we really, really wanted to up our game on in terms of understanding clinical effectiveness across the board. So those are the outlier reports that come to us, from the national teams that are scrutinised and we have to respond to. So all of those definitely come to Quality Assurance Committee, and those are the 3 that we've most recently been looking at. If there are anything else that loosely might fit around mortality but more directly against clinical effectiveness, so things like the Getting It Right First Time programme, the peer review stuff, again, all of that comes to Quality Assurance Committee, and it's reported on every single time that we meet. So again, very happy for you to come and join us at one of the committees and see how that works, and if you've got any further suggestion, always gratefully received.
Thanks, Jane. And then readmissions within 28 days.
So readmissions, again, it's one of the criteria we monitor, and we'll have to go back to the team and ask about the 14%. I understand where you're coming from when we're looking at the process control charts and actually what's normal and what's we don't have a comparator, if you like, with other trusts. So actually what that's showing you is actually our own progress or lack of progress, as you perhaps have just highlighted. I would ask you to also think about it also in the context of safe discharge and unsafe discharges that are monitored. But again, we can pick that up a bit further through the next report at QAC. And then finally, never events. We very definitely review all of the never events at Quality Assurance Committee. They're reported to us as part of the patient safety reporting. And very particularly, we're focusing, as you would expect us to do, on the learning. They are also reported to me independently as Quality Assurance Committee at the time that they happen as well. So they are closely monitored, and as I say, whilst you might not see it directly event by event in the IPR, I can assure you it forms part of the quality report.
Can I say something on the never events once more?
Of course.
It's very nice that these events are properly monitored and looked after, but the knowledge stays with a small group of people who've been intimately involved. The idea of any report is it should go out to a wider audience, which can learn from other people's experiences where they have not been involved in the first place. With regard to mortality, this has been my hobby horse and I've done quite a considerable amount of work. The way the data is, I can't take that book to the chairman of the Quality Care Commission and say our mortality is well within normal limits, because it's the way it is displayed, it does not help.
Thanks, Professor. That is really, really helpful. And clearly we have got other systems for scrutinising, as you've rightly said, in terms of mortality through the trust. But we will take on board what you've just said, and I think we should have a further conversation with you. I think it's really important.
I think your point, particularly about never events, goes much beyond just the quality agenda, doesn't it, Pervez? It goes to the heart of what a learning organisation is and a continually improving organisation. And there is no trust in the country that is outstanding that has anybody sitting on the lessons from never events that are fully and properly disseminated the length and breadth of the whole. And more importantly, that the Quality Committee and the Audit Committee have evidence that not only has the information been disseminated, but some evidence that that is now built into new and different practices that are sustained over time across the Trust. So, I mean, I think that is the holy grail in terms of us taking a significant next step up in terms of, you know, our approach to outstanding across the Trust.
Thank you.
So no pressure on the chair of the Quality Committee and all of that, of course. Thank you for the challenge, Pervez. That brings us on, if we may, please, and we're going to leave that report there, but I'd like to thank Margaret for her feedback earlier that she thinks the report is in good shape. And I think the good conversation too has borne testament to that. So thank you, and thanks to the colleagues who worked hard to get it in that form. So item 6 is the next item, and it's about restoration and recovery. Just to do a time check, it's now 2:30, and we're scheduled to finish the meeting at 3:30, so we've plenty of time. But between now and then, we do want to do credit and justice to restoration and recovery, and also the care accreditation scheme as significant items. And also we need to have a short discussion of a few other things, including the quality accounts. So I say that just as a gentle guide to colleagues who are about to take us through the next items. So I believe you're up for restoration and recovery, Bernice.
Thanks, Helen. Can I just check, Nick, you're okay to share the slides? Thank you. I'll fly through these and just answer questions. I think it'll be no surprise to anybody at all that restoration and recovery has been a real challenge over the last month. There's been real difficulty with the increase in COVID patients that we've had through our doors, the number of outbreaks that we've had, and what we referred to earlier on, that there has been real difficulties in the flow out of the organisation and accessing kind of care in people's own homes, which is the best place for them, and also in some of our care homes and nursing homes. As a result of all of that and our normal winter pressures that we see, despite trying really hard to ring fence our elective capacity, we did have to stand down the majority of our theatres and use our surgical areas to manage some of our medical patients, unfortunately. As Angie reported earlier on in the Chief Exec report, it's really positive to see that we're back out of those areas now, and we have got our theatres back up and running, and we are steaming ahead with our elective procedures. Just to reassure people that through this period we absolutely have ensured that our urgent procedures and our cancers have been supported and have gone ahead. So we've refrained from cancelling any of those procedures where possible, and we have been able to keep a number of day cases ongoing as well. So I've put a few slides together. I'm just going to take you through a few headlines, but as I say, then just hand over to people for questions. So if we can flick straight onto slide 3, that'd be great. Thanks, Nick. So just a summary around kind of our recovery position. Our elective care pathways have increased, so 5 weeks for new appointments. You'll recall the last time that I came to give a report on this, we were actually at a week for our new patients, and we're now at 22 weeks for follow-up appointment, with 24 weeks on average for our elective surgery. I have to say though, when we do look at the benchmark across other organisations, we are in a pretty good position with regards to 24 weeks for elective surgery. Our waiting list continues to be impacted with 4,807 additional new patients and 21,000. It just seems an enormous number, doesn't it? And 35 additional follow-up patients. But with the introduction of the patient-initiated follow-up, that will be a real support for us. What is a real positive number there is that we're still running at about 24% of our patients being seen virtually. A lot of our organisations have retracted back as the pandemic's continued on, and some of the new initiatives that have been implemented, they're down to about 15% for their virtual assessments of patients, and we've continued, the target's about 25%, but we've continued to keep that at 24%, so it's really positive. If we can click straight on to slide 5. Thank you for the thumbs up there, I don't know where it came from, so thank you. Just a bit of background around our kind of 21-22. So this was currently for this year, which we've just got a couple of months left, believe it or not. Supporting the health and well-being of staff, really important. The NHS COVID vaccination programme, transforming delivery of services. So we've continued to do that despite the challenges that we've seen. You've seen in the success measures the amount of transformation that's still been ongoing through 21-22. Expanding our primary care capacity, and there's been a real increase with the winter capacity that we've actually had, and the number of patients that are able to access same day face-to-face appointments is increased substantially over January, and will continue over February, which is positive. Transforming our urgent and emergency care service, which you're well aware that we've done some work on that. And then the guidance talked about eliminating our waits of over 104 weeks by March 2022, holding the number of patients over 52 weeks and stabilising the waiting lists by the end of September 21. As I said earlier on, because we've seen the increases added to the waiting list, it's been a real struggle to do that. Our position around 104 week waits, we are currently sitting at 85, but the trajectory that we've got in place is certainly going to bring us down to 50. We are kind of micromanaging the 104 week waits. It's not a nice term to use, but we're just monitoring every single one of those patients, making sure that they're booked in, to try and get them down even further, because we need that to be as low as possible to give us a fighting chance next year. If we can click on to slide 6, Nick, thanks. Just an overall summary there, that our elective care performance for December was 8% above the threshold, but 1.8% below trajectory. Our day case overall position for December is not achieving, so that and the inpatient levels, the overnight electives, is not achieving. So the area that's bringing us to a decent position and achieving our actual thresholds is the outpatient activity, and as I said, some fantastic work around the PIFU, the virtual clinics that's in place, advice and guidance. Another one, just to kind of pull out there, our overall diagnostics are doing extremely well and all above targets, and our cancer performance has remained stable, which is again a reflection of the fact that we've been keeping those pathways moving. Thank you. If we can just flip to slide 8, thanks. I just wanted to highlight some improvements to everybody. So around the urgent treatment centre, the model commenced obviously back in February 2021. We've consistently had above 500 attendances a month coming through there. The recent changes has meant that there's over 1,000 patients through the UTC, so we're managing to stream a lot more patients into that area, but just bearing in mind that it's due to the flexible workforce where we've seen emergency department consultants go and see the patients in those areas, as well as GPs, advanced nurse practitioners from community, etc. So a real flexible model that's been a help. The Trust committed as an early follower to the 111 direction tool, so that was launched back in early December for us, and since the 2nd of December, the 4th of January, we've had over 1,000 patients there using the tool, with 27% self-referrals to ED. So some real positive actions there. We did put extra security in place because we were advised that when it was implemented at Portsmouth, there was a lot of resistance and a little bit of aggression actually when we tried to redirect people away. But actually we've stood that down. We've not had the issues, and I think some of it is absolutely down to the way that the team at the front door have the conversations with patients and offer them direct access into some of our other urgent treatment centres across the county, which is really positive. Just want to mention frailty as well. Frailty's moved down from Durham, where it was in situ, is now at the kind of the front doors with the rest of the assessment units. So it sits alongside our acute medical unit and our short stay unit, and alongside SDEC as well. So a real good ethos around turning people around. And I have to say, that alongside same-day emergency care has been our saving grace of really trying to turn people around and make sure that patients are only admitted if they really do need to be in an acute bed. So there's been some really positive outcomes from that. And then again, with the same-day emergency care, both medicine and the screen's just gone off there, medicine and for surgery as well. Really robust pathways that add into it all the time. We are moving ahead with the direct referrals for paramedics to be able to avoid ED altogether and access those services. So yes, really positive development there. The rest of the slides, I'm not going to go through, Helen. They describe what Angie was saying earlier about the operational planning for next year and the areas that we're focusing on, and it's just to give the governors a flavour of where our focus is going to be leading to and what we're going to be making sure that our transformation plans focus on as well. Thanks. You can stop sharing. Thanks so much for your help, Nick.
Thank you very much for that. Not only a tour de force in terms of presentation and ground covered, but the sheer volume of business we're managing to get through the hospital. It's phenomenal, and it's a kind of relentlessness in terms of colleagues giving their very best, but also, Berenice, the new ways of working and the constant innovation you've brought to bear on all of the areas you've described. So a very big thank you from all of us for that.
Thank you, Helen. And I do know John's point about too much information and data on, especially the slide that shows you all the different pathways. So we'll have a look at that and see if there's a different way to present that. Thank you for the feedback, John.
Now, would anybody like to follow up with anything you've heard or read on those slides? Happy to note the report. Yeah, it's a very impressive report. So thank you again, Berenice. I'm going to suggest that we take 5 minutes. It's 20 to 3. And if we could come back at 2:45 with our glasses recharged or a fresh cup of tea or whatever, depending on the speed with your kettle boils. And then we will go to the next item, which is the presentation on the care accreditation scheme. We'll see you all just after 2:45, I should say. And we're now going to go to item 7, which is the update and presentation on the care accreditation scheme that Jane promised you earlier on the first item on the success criteria report. And I think this is duet, is it, with Sarah and Krishna?
Well, it's mainly Sarah, so I'll let Sarah present. We can both answer any questions.
Lovely, thank you very much.
Thank you. Nick, are you okay to share? Thank you very much. So just in terms of background for those that care accreditation will be new to, care accreditation is a method of understanding the quality of care delivered at the bedside and in our departments. So the Chief Nursing Officer for England, Ruth May, has care accreditation scheme as one of her strategic goals to have in every hospital trust throughout England. And we've been in progress with our care accreditation scheme now since 2019. And for us, it's been very much an improvement focus and a stretch target to get us on to outstanding. Next slide, please. Oh, I've always wanted to say that. So just to provide a bit of context, you'll be well versed on how disruptive COVID has been. So over the last 2 years, we have conducted over 29 ward moves, and I just pause after that figure because when I was pulling this together, that there is no wonder our teams, our patients, our services are disrupted with that level of movement. It is incredible given the context of work that Berenice has just described that we've conducted despite all of those moves. And that doesn't include our same day emergency care relocations and our discharge lounge relocations, which one day our discharge lounge relocated twice in a day. So I think suffice to say, it's been turbulent. And we've been in this response period for 2 years now. On top of that, there's been a high level of staffing absence in different forms and in different waves. And the acuity and dependency of our patients has changed throughout that time. So we aren't having the same number of elective patients coming through. So they are the sicker of the patients that we are seeing because they're the ones that need to be in hospital. So that's really changed the picture and the care levels that have been required. On top of that, our ACE assessment, so our accreditation of care excellence, for us that's ACE. The depth of our assessment when you look in context to the rest of the country is phenomenal. We've benchmarked against numerous trusts up and down the country, and what we are asking of our ACE assessment is considerable, but we do that on purpose, not to make it difficult for our teams to achieve, but because we are really ambitious and we want to stretch those targets because we want the very, very best for our patients. So we always set this out to be a 5-year project, and we unfortunately haven't had a full year effect yet. So we launched in July 2019, and we haven't had a full year effect because of the disruptions. So given all of that context, I think what we've managed to achieve to date is considerable. So the next slide will show you where we are currently at in terms of our assessment progress. So this gives you a little bit of a dashboard of our wards and split into divisions. So the colour coding will tell you we base our assessment rating on gold, silver and bronze, and a foundation level where wards haven't achieved that bronze status, but they've got a good foundation basis. We've purposefully aimed it at bronze, silver and gold so that this isn't rag rated, this isn't about punitive, this is about success and achievement, and it is very much based on an improvement methodology, and we are linked in with the Improvement Academy, so we make sure that all of those improvements are linked into the Academy. So you'll see from there, in terms of Council of Governors success measures, we did 16 wards that were in scope for phase 1. So those will be the coloured everything but pink. The pink haven't been assessed yet. The 16 wards in scope for phase 1, 5 were bronze, which is 31%, and 3 silver, which is 19%, and 8 white, which gives us 50%. So to achieve silver, and I invite any of you, if you would want to join us on an assessment programme, to achieve silver is something considerable, and to achieve gold, those wards and areas will need to achieve silver on subsequent assessments and then come to a panel with a portfolio of evidence. So we are not making this easy for our teams. Next slide, please, Nick. So the themes that we've picked up throughout our assessment, and interesting, we've touched on nutrition and fibre and etc. That hasn't come up during our assessment, but nutrition and hydration for sure has been a key theme that we have identified, and that's been around mealtime delivery, the organisation of that process, fluid balance charts and care planning. And these things are all being worked on currently. So mealtime organisation, fluid balance chart through a digital platform, and care planning. We have a documentation group developing a better platform for care planning and then teaching our staff how to use those well. Falls, you'll see the falls through the integrated performance reports, and the key themes that we've picked up on are lying and standing blood pressure, that we're assessing our patients from a medication risk, and we've introduced post-fall assessment, so a rapid learning post-fall, so that we can actually integrate that learning and make a difference to that patient and hopefully prevent a further fall for that patient, because we'd recognised a theme with recurrent falls with individual patients. So that's been really, really positive. Safeguarding, a large agenda around Mental Capacity Act and documentation of that, and as part of our CQC must do and continuing improvement around deprivation of liberty safeguards. Tissue viability, that's been around care plans and surfacing and repositioning. What we've been able to do, thanks to investment from the board, has been to create additional resource within the tissue viability team. So all of those pressure ulcers that are identified are validated by the specialists, given advice at the time, and we're able to make a real-time impact for that patient during their admission. Infection prevention and control, we've embedded COVID assurance throughout the pandemic. And our documentation is an ongoing theme, and we currently ask the question of our staff, can I care for this patient based on what's written? And that is our simple premise. Because we've moved staff so much, staff documentation has really been very, very important. So I pull all these out really to provide assurance that whilst our care accreditation programme has been paused, all of these themes have been being worked on during that time. So work has not stood still. Next slide, please. So what have we been doing? Despite all the work on those, as I've described, we've been working really hard with a digital company developing the assessment on a digital platform. So the current format is on a spreadsheet. It is very labour intensive. And only one person can work on that spreadsheet at a time. The report writing takes a couple of weeks to pull all of the information and all of the data together after the assessment. And of course, our teams are urging to know what their rating is, and they want to get working on the things that they haven't got right. So the impact of having a timely report is really, really important. So we've been really pushing hard on this digital platform and a really good relationship with this company. What we are doing, first off, much of our day-to-day kind of nursing audit, which we call our patient-centred assurance, has been already transitioned onto this platform, and that feeds into the ACE accreditation. So already half of our report is effective. We've got all of that data to triangulate when we then go and do the go seeing on the wards. The benefits of the platform in how we're building it, it will give you a ward level data, it will give you a care unit data, a divisional data and a trust-wide oversight. So hence the oversight plus the granularity right down to each individual question. You'll be able to drop down to see any trends in any individual area. We've been testing on critical care. Our paediatric and our maternity standards are currently in progress, and they are very nearly there, ready for testing. So again, all of that to say, whilst we are paused, we've not been stood still. Next slide, please. So the company that we are working with is Genome, which is a quality improvement data analytic company. And what they are helping us to do is to integrate all of our quality improvement audits into one place. So we aim to get to a position where, for example, our COVID assurance, some of our infection prevention audits, our meds management audits, etc., are all pulled into one platform, so it will triangulate and give you a really, really detailed picture of what care quality looks like here. As I described, you'll have a dashboard view, and the really, really key piece for me is that local ownership. So our wards are really owning this data. This is their data, and they can see it immediately and start working on it immediately. And not only are they able to see theirs, they're able to see everyone else's as well. So we looked at it to begin with, and there were 3 options for visibility, and that was auditor, manager, or executive. And that gave the auditor view of their own, the manager view of their group, and the executive view of all. And we've given executive view to all, because it's really important that they can see. And as we described before, that we learn from everybody else. If someone else has cracked something, let's learn from them, and let's not go looking, let's have it at our fingertips. So the data sources are grouped really intuitively. It's really quick and easy to go and do it because of how we've grouped it. So if a number of questions are gained from looking in the medical notes, those questions are grouped together, so you only have to look in the notes once. You don't have to go back when you go further down the questions. And the company has been so responsive, and they adapt it bespoke to our needs. In terms of value benefits, we've kind of described that, and I think the key for me is that local ownership and the immediacy of the reporting. Next slide, please. I did share this with Keith Nurcombe from a digital perspective, and he said he urged me to bring it to this group and wider, because we've negotiated a fairly hefty discount in that in the first 2 years it's costing us nothing. And whilst this is a public meeting and potentially commercially sensitive, I won't describe what it's costing us for the next 2. Suffice to say, he feels we've got a very good deal for what is being delivered. So I've just done a couple of screenshots so you get a little bit of a sense, recognising it's very difficult to see on here, but a little bit of a sense of what a ward view might look like. So Nightingale ward, for example, the standard that we would be looking at down the side, and then the trend of their improvement and the result of their last audit. And the next slide, please, Nick, will give you then a divisional view. So that's all of those wards grouped together to give you a division. And I haven't put in the trust-wide view, but the trust-wide view equally would give you that aggregated dashboard. The benefits of this are that, thanks Nick, a number of our wards, our nurses in charge have a mobile phone. This audit is optimised for mobile phones, so they can do it on the mobile phone and audit at the bedside. Our previous systems were you would have to, for patient-centred assurance, you would have to do 10 in one go, and remember 10 patients in one go, and remember which patients you'd been to. The benefit for this is that you can drop in and out of this audit and do it over a 4-week period of the month. There was an audit day previously to that, so it's been really helpful in terms of releasing time to care as well. So our proposal for this year is to regain confidence through a reassessment programme. I would love to be able to say to you that we'd be able to assess every single ward this year. We are not going to be in a position to audit every single area on the dashboard that hasn't yet been assessed. What we will be able to do is to assess all of our inpatient areas to regain that confidence from where we've been before, recognising the movements that we've described, and that we need a further baseline, and we will prioritise the white areas. We've done a trial in critical care and we really want to establish a baseline for them, theatres and the birth centre, and then the plan would be for 2023, COVID allowing, that we would have a full programme of works. Any questions?
Well done, Sarah. Yeah, take down the slide, and then we can see it was a really impressive and fabulous progress despite all the trials and tribulations of COVID. So well done. Jane, please.
I just want to reiterate thanks, Helen, because I think it's been such a difficult time, and actually the progress that's been made is absolutely phenomenal. I mean, I'm quite blown away by the presentation that Sarah's given us this afternoon. I've been fortunate to go on 1 or 2 of the visits when we first started them, and I would like to just say to governors, the rigour with which their evidence is tested and the rigour of those assessors is absolutely tremendous. So, just to say, if you get the opportunity, it is worth going with Sarah just to see how it's done. I also was really impressed when she's just spoken about the documentation bit, because one of the things that we noted from one of the early visits was that documentation is really difficult, and actually as a nurse going on to a ward, you really need to know that you can safely care for any patient that's on that ward. So is the documentation up to standard, and actually does it tell us what we need about our patients is really critical, alongside all of the other elements that Sarah's described. So I just wanted to say I am absolutely blown away, and I think Sarah's done an amazing job, and thanks to the leadership of Krishna on this, I think we're going to be in a great place soon, and I actually really welcome the fact that we've got the digital platform, and actually we can really give absolute ownership to our care units on the quality of care that they're delivering. So well done, everybody.
Thank you very much, Jane, for that vote. Thanks. Margaret.
Hi. Thanks, Sarah. I'm not sure if I missed it at some point in your presentation, but how frequently are each of the wards actually visited to do an accreditation?
So that's a really good question, Margaret. So it's based on the outcome of their assessment. So, for example, if that's a silver assessment, we wouldn't go back for 6 months. If it was a bronze, we would go back in 3 months, and if it was a white, we would really have an understanding of what we wanted to achieve. So with the support of the Improvement Academy, we've put in an improvement plan, which is a 30, 60, 90 day plan, because they need a little bit of time to act on what we found. And we'll do that alongside them. So that was another reason for pausing the accreditation, because it's like testing your homework but not telling you the correct answer. So what we didn't want to do that for them. It's absolutely based on improvement, and that's why we've got the buy-in that we have, because we are alongside them, then showing them what good looks like, what outstanding looks like, actually.
Thank you.
Thank you both. Luke, please.
Yeah, brilliant. Thank you. And again, I might have missed the beginning. I might have missed my question because I got called in something right at the beginning. But it was just going back to what Jane said about the assessors, and there's lots of rigour there and it's robust. I was just, I guess, gaining assurance that the assessors are from a wide variety of backgrounds. Yeah, of course, I'm going to ask that, being an AHP.
They are absolutely, and that's a really good question as well, Luke. So our standards for ACE assessment are grouped into, there are 11 standards now in total, and they're grouped into, for example, skin integrity. So the lead for that standard to gain consistency will be our tissue viability team. So that gives us, we know then that across our assessments, we have a consistent standard of assessment. So not only are the questions standardised, but the assessor and their perspective is standardised as well. The same for safeguarding, will be one of our safeguarding team that will lead that view. We have AHP supporting our falls, etc. We have pharmacists supporting the meds management. So yes, you're absolutely right. Our patient experience team with the patient experience standard, they are a really they're a key core team, and whilst you've lauded praise on me, I have to in turn laud it on them, because they are just incredible in offering up their time, because we've had to carve out time for this and find it. But it does support them to have that granular detail at bedside to really know what's going on, and that includes our heads of nursing as well.
Brilliant, thank you.
Pervez, please.
Splendid piece of work, and once it is up and running, I'm sure it will be very good for the patients and the staff. I have one question. Do we have vision that come a year or two into the process, none of our ward will ever be bronze, it will be silver or gold?
You're absolutely right, although I might be a little bit cheeky and stretch their targets. But we said we wouldn't, joking apart, we said we wouldn't change the questions and the standards. We would do an annual review, but we would only change them every 2 years, so we get a stability of what we're assessing. But once they're finding it easy to get silver, we'll be stretching them.
Thank you. Judy.
Yes, thank you very, very much for a wonderful report. It's really very good, and I think it's a really wonderful for the future, for standards. It's just a question that may be irrelevant. I'm just wondering, it was around the phrase, would anybody coming onto the ward know how to care for this patient? Where do the psychological assessments, and I'm thinking it may be coming under the safeguarding issue, but it's a really common thing that trusts, physical care trusts, are failing to pick up on these mental health issues that actually can lead to disaster. I'm trying to be fairly tactful here, but I'm just wondering how the assessment, which I think is great, would pick up on those sorts of issues which are hidden.
You're absolutely right, Judith, and I can provide reassurance without showing you in detail. I can provide you reassurance that all of those things are collected within, well, they are within the safeguarding, but they run throughout. So they're within each of the standards, because each of them, whilst they are standards in isolation, they are very much a unified assessment. So it's a holistic approach across. So there will be some elements of what you described documented in the case notes. There will be some elements documented in nursing records. But more importantly, what happens during the assessment is the conversations with patients. So not only do we talk to the staff and we observe and we look at notes, etc., we spend a lot of time talking to the patients and really hearing from them what their experience is. And I think that's really, really important, because sometimes we see some things that perhaps haven't been written down. We hear some things that perhaps haven't been written down. And we're told some things that perhaps they haven't been able to share in another way, or haven't been heard maybe. But equally, we do see really good documentation at times as well. So we're really keen to highlight the good practice as well as areas for improvement. But I think, again, one of the successes is that the involvement of patients in this and families as well, and where we've been, families have asked us what we're doing. Families are often, well, we feel really quite safe now knowing all this is going on.
Yeah. Could I just have a quick comeback, please, Helen? Is that okay? Do you then have the ability to call on people from different specialities to ensure, if you do realise there's a psychological issue?
Yes, it will obviously depend on what that psychological issue is, but we do have access to crisis teams, we have access to different psychological supports, we have access to our own internal kind of dementia specialists, for example. So yes, we have a range, and we absolutely will.
Thank you very much.
Thank you both very much. Now, Krishna, I'm going to pass to you for the very last word on this. So whatever you want to say, and perhaps you might wrap us up.
No, thank you very much, Helen. Thanks, Sarah, for the brilliant presentation. Now, all I was going to say is that obviously the leads all triangulate sort of their findings after the initial assessment, and Helen and myself go also at the end for that high level with the ward leaders to see what that feedback is. So it's triangulated, and that's really for us to hear. And we do hear what the assessors have found from how compassionate care we see that, and we feel it and we hear it, that mop up sort of from an assessment point of view. So it gets translated. If there's any issues that Hal and myself need to escalate either through sort of medical, sort of nursing or AHP to sort of instigate sort of interventions there, then when we can do that. But invariably, it's feedback to different teams and praise for different teams on their interventions that we get. So we do have that feedback. So it's well triangulated, sort of the information that's collated during the assessment phase from the leads. But just to give that assurance, and it's fed back to sort of the MDT teams as well. Thank you.
Well done to both of you. I won't reiterate the votes of thanks, but you know, it's been really splendid to hear about that magnificent work. And as Sarah said, it must be a great comfort to patients and families to know that we're taking this really targeted approach to improving quality. So very well done. Now, I make no apology for allowing us to have had really good discussions about our Chief Exec's report, the success measures, and 2 great presentations. But the implication is now that we must do the rest of the agenda at not an indecent gallop, but a jaunty canter. So if colleagues again would take that as gentle steer, please, for the next items. The next up, which is item 9, the communications update.
Thank you very much. I will go at a suitable speed, Helen. Thank you. Good afternoon, everybody. I think I've met everybody on the call. I've been enrolled since autumn and continue to thoroughly enjoy working through some significant challenges, as we all do. I'm really proud to work as part of Team CRH, and I think, as has been already outlined on the call, there's lots to be proud of and there's lots to communicate out there. For those of you who haven't met me, I'm Associate Director of Communications and Volunteering Services here at the Trust, and my name's Carly Thompson. I should have probably gone in on that, but I just assume that everyone's cottoned on to that by now. So nice to meet everybody. Lots of great work has gone on before I arrived, and we continue to build on that. And I just wanted to give you a quick overview as to where we were and what we were doing at the moment. So we continue to engage and involve our internal and our external stakeholders in what we're doing, and that includes everybody from the national team, NHSC, where I have, it sounds like I've been in prison, but where I have served time, and also through Joined Up Care Derbyshire and the work that we're doing with Joined Up Care Derbyshire. I've really enjoyed recently when I joined the meeting, the the Engagement and Inclusion Committee with Nick, and obviously I've met many members of governors on there already, and continue to look at how we develop communications. So the approach that we're looking at as a communications team is looking at how we develop planners and be more proactive around our communications and looking at our priorities, and that continues. So the work we're doing with the charity, the urgent and emergency care development, DSFS, the membership review, equality, diversity and inclusion. This morning I had a really exciting and interesting meeting with several colleagues in different departments around the organisation. So lots of positives that I could go on and on about for those that have heard me do so. But our priority is to focus pretty much around currently a 3-word strategy. And if I may, I want to leave you with what they are for us at the moment, and that is acknowledge where we are and where we've been. Talk about the action from where we're going and what that looks like in terms of the great work that Chesterfield and our partners continue to do, and look at the ambition for how we're going to drive that forward and continue to continually improve. We have focused this month, as you'd expect, on our operational pressures. COVID and vaccines have been our biggest input from our externals and our biggest inquiry from our media sources. So the mandatory vaccine, the number of COVID patients, as you'd expect. We're also identifying a number and addressing a number of resource issues across the team, and we'll be looking to appoint some new faces based on some secondments and some maternity leaves that are about to be taken. In short, we are getting more proactive. We're looking at how we work better with our partners and with others, and continually want to plan for the year ahead, and the work that we've got in place should hopefully help us achieve that. Breakneck speed there, but ultimately I'm here to take questions and really happy to continue to meet outside the meeting if that would be useful.
Thank you very much, Carly. It's not surprising that somebody in communication should be able to cover a lot of content. We're grateful to you for doing that justice in the way you have. Obviously this is the first of, I'm sure, many updates you'll get from Carly. But if there are any particular issues you'd like to raise now, please indicate. Well, we'll look forward to your next visit, Carly, where no doubt the strategy will be a bit more evolved, and I'm sure you will want to take Governor's views on that at that time.
Very much so. Thank you.
Thank you. Margaret, I do apologise that I did obviously get into a slightly indecent gallop because I went straight across the update from the non-exec directors and governors meeting. So if we could go to that now, I'd be very grateful.
Yes, I was going to mention this at the end if we didn't get there, but I won't say very much. I mean, the idea of this report was just to, you all had the report that Jane kindly did at a previous meeting about the meetings that we had together. I've tried to pick up on all the points that were raised there, just describe to you a little bit about some of the things that we've been doing. I don't need to go through it all. You can read it just as much as me. Just apologies that it still says draft because that should have been taken off. But yeah, I mean, a lot of the things are going to be ongoing, but it's been lovely to have meetings with Krishna and with Carly to talk about some ways to go forward, and yeah, we just to reassure you that we are working on actioning a lot of the points that you talked about, and perhaps I don't know if it might be useful, Nick, if we can send the new governors the previous paper so that they can match it up with that, if that's possible, because you really need to read the two together. But I've nothing specifically to say. If anyone's got any questions or things they want to raise, then I'm happy to take them now.
Thanks, Margaret. I think it was a great initiative to have these conversations, and I think the two of you have completely put me to shame in terms of having that great list of asks and responses. I mean, I've often done these in previous years, and we haven't had that sort of bit of paper. And I think it's really good in terms of keeping us honest. You said we did, and I think the discipline of it's great, and the format of it's fabulous, and it's a nice point of reference for us. And I hope particularly good for incoming governors to know that, you know, if there is something that you want to have influence or shape or have an impact over, there's the council meetings, but also that opportunity in dialogue with Margaret and Jane and myself. So thank you very much for that report, Margaret, and thank you also, Jane. If I can just go back to item 10 now, please, which is the issue from the Governor's pre-meeting. I have managed to wind 8 of the 10 items that were raised in the pre-meeting into other parts of the discussion today. So there's only 2 to share for the public record. There were two more. One was about Hospedia, issues about the adequacy of patient access, the cost of patient access, and a request that we find out the timing of the review of that contract, and are we adequately prepared for any arrangements that might be required at that time, or any negotiation we might wish to consider in the run-up to it. So that was one. And the second was about the risk register and the fact that it can on occasions be impenetrable, and I was able to report the work that's being done in terms of simplifying and bringing that to life. So they were the 2 other items that were mentioned in the pre-meeting that we haven't addressed elsewhere in this meeting. But as always, the minutes of this meeting will include a table relaying all of those items and a full response to each. So I think I can probably leave that report back there. So if colleagues are content with that, we'll go to item 11, and item 11 is governor feedback. So this is an opportunity for any wider feedback from governors who may have been at meetings, or places you've been, things you've seen, and things you might want to tell colleagues. Is there anything further from you on this item, Margaret?
Yes, I was just going to say I've attended the Derbyshire Engagement Committee again recently. One of the main topics that we talked about there was a presentation about the Integrated Care Board and the potential subgroups, if you like, of that, subcommittees of that board. And I mean, there's nothing fixed in stone as far as I understand it yet, but there was a bit of a conversation about governance arrangements and where non-exec directors of the provider organisations might fit into the board structure. And I wondered whether the Royal as a board have actually had any conversations around this, because we were just sort of asked for any ideas or any thoughts about both where ourselves as governors and where possibly some of our non-executives might actually feed into the Integrated Care Board. So have we had any discussions around that? Because I mean, I personally didn't actually make any comment at the time because I wanted to take it away and think about it a bit more, but I don't know whether we've, as an organisation, have had thoughts around that at the moment.
Yes and no. So the situation at the moment, Margaret, is that the Integrated Care Board have gone out for, I want to say 5 non-executive directors. I hope it's not 4. And there's going to be an equal number of non-executive directors to executive directors, so we could probably count them up, actually, couldn't we? And then John MacDonald as chair will be the kind of, the majority of non-executive directors on the board of the ICB. Yeah, so there will be a majority of NEDs on the ICB. And they have to be independent NEDs. And there was talk in a previous, iteration of proposals that they will be drawn from the providers, but they won't be. They'll be completely independent. And I'm encouraging that, in addition to whatever it is they need to do as an independent NED, that they might be given a role with a liaison responsibility with providers, so that we have an opportunity to have that dialogue with the non-executive member of the board, in addition to the existing relationships between executives. And each of those INEDs will have responsibility for chairing or being on one or more committees. And the discussion about the involvement of NEDs is in respect of those committees. Whereas I understand that they wouldn't be members of the committee, but they would be invited observers to the committee. And that would somewhat mirror the situation that is envisaged with the ICB itself, in that there are members of the ICB and then there are a variety of observers. And the reason that there are a variety of observers who I think will be invited to participate is so that we don't dilute the extant partnership through lack of presence or input or insight from the various parts of the partnership. So I think the answer to your question, Margaret, is that everyone knows it needs to be thought about. We can see places where there is an obvious opportunity to involve people, but nothing is yet settled. Not least of all, of course, because there has been no announcement yet about the appointment of the NEDs to the board of the ICB.
Yeah. Thank you. But yeah, as I say, and the other things that were mentioned at that meeting were there's nothing particular that needed to be highlighted, but that discussion is ongoing. It's about all these issues. So I'll let you know. And they've also stood the meetings down to, instead of monthly, to bi-monthly for the time being. So I shan't be hearing anything more for another month. So
thank you for that update, Margaret. Anybody want to come in on any of that? No, happy to note the situation. Yep, thank you. So that brings us on to the last substantive item of the meeting, which is the quality accounts item. So it's item 12, and you've got a proposal on this paper, which is that the Engagement and Involvement Committee of the Council of Governors be asked to prepare a commentary on the quality accounts. So that's what's before you for consideration. I don't know if there's anything else you want to say, Krishna, to set the scene on that.
No, that's it. No. Thank you. Yes.
Are colleagues content with that proposal? A few nods, a few thumbs up, virtual or otherwise, because very good. So that work will be taken through the committee. So little job coming your way. So many thanks for that. And then if we just go back to the agenda, we're now in the consent items. So we've got the minutes of the previous meeting in the consent item, and we've got the performance report that we've already had some helpful questions on in the consent item. So we will will approve and note those accordingly. And that brings us on to any other business. So can I ask you to put up your hand if anybody wants to raise any matter of other business? No hands that I can see. So that leads me to tell you that the next meeting, believe it or not, we'll all be at Easter or maybe past it, is Wednesday, the 27th of April. And wouldn't it be lovely to think that we might all be in person? But obviously we'll keep you updated on that as we get closer to the time, but that will be something to look forward to. So let us just now pause for a bit of reflection on today's meeting. What went well, what could have been more effective, and we've been good role models of leading the Chesterfield way. I'm going to, in kind of time-honoured tradition, go to some of our new governors to share with us, if they would, their reflections on the meeting, how it was for them. Carol, can I ask you to lead us off?
Right, I think I've done it. Again, like every meeting that I've attended so far this year, quite broad, quite wide-ranging. I think as a new governor, a lot of stuff coming in, and it's about accessing it and being able to read it in a way that it kind of sticks instead of on a screen. So I think that's something that we've probably all had to get used to as a result of COVID and not meeting in person. So hopefully that'll get better as the year goes on. But just nice to see from another aspect about the amount of work that's done that I've kind of previously perceived as a member of staff. So it's nice to sort of see that the wider context of the discussions that have taken place and the amount of work that it's obviously taken to be able to do that and to bring these papers to a meeting like this. So yeah, it's been valuable. Thank you.
Very good. Any of the other new governors like to add any comments on how today was and how they found it? John.
Thank you. It was very interesting. Lots of information. I have found my printer's been going very rapidly, in the background because I tend to find that I need things laid out in front of me. So if some printed material could be posted, that might be useful. Because I'm coming up to pensioner age and I've got to watch the pens.
Looking well on it, John. We've tried to avoid that, but if on specific cases or specific individuals with particular requirements, we'll absolutely meet those best we can. So we'll ask Nicola to follow up with you on that, John.
Yeah, it's purely and simply because I absorb visual information rather than everything else, so I need to concentrate on bits and pieces. But that's specifically because of my Asperger's.
Absolutely. Yeah, we will follow up, John, with you on that. Thank you for those reflections. Nick?
Yes, hi. A few more pieces of the jigsaw puzzle have fallen into place as a result of the meeting. As you can guess, all of the new governors are on an extremely steep learning curve. But just touching upon something that was raised earlier, I think it might have been John, we do get a mountain of reports that come through. Some of them are very well written, easy to read, very concise, and others would have contract lawyers up and down the country applauding, and the Society for Plain English pulling their hair out. I just wondered whether really we should be promoting simpler messages, easier to read reports, that we didn't have to reread sentences or paragraphs, that it was quite obvious from the word go what was intended. I just think that there is a tendency to overcomplicate things at times. That's the only point that I wanted to make.
There's a few nods going on, John, which of course is the beauty of having fresh pairs of eyes around the table. So we will consider ourselves duly challenged to kind of get better in that regard. And periodically, you just do need to review that. So thank you for that challenge. Anybody else like to comment on today's meeting? Well, if no one else moved to share their reflections with us, the last thing I'd like to say is that whilst Angie doesn't retire until the end or till the middle of I'm not sure what this. Well, I'm not sure, Angie, because your time is some way away. But I'm not sure if this might actually be your last formal meeting of the Council of Governors. I think it might be.
It is.
In which case, I would like you to take a vote of thanks and appreciation on account. I do hasten to add that governors will be invited to a suitable opportunity to give Angie that full vote of thanks and appreciation. But I obviously to record it for the minutes and to at least say in brief, Angie, that your attention to all things of the trust, but in particular and relevant to this occasion, the quality of and supporting the quality of dialogue we've had at Council of Governors, including through the focus on the success measures, has something that has been much appreciated by governors. So, as I say, if you will take that on account in advance of a more fulsome acknowledgement and appreciation of your time with us in due course.
Thanks, Helen, and just thank you to governors who've sent me some lovely messages. I really appreciate it, and see you all before I go.
Lovely. Thank you, Angie, and thanks to all of you for your best attention and participation this afternoon, and indeed for your great help in getting us to the end of the meeting more or less on time. So well done, and thank you all, and see you soon.